Great.
Good evening, everybody. Welcome to another episode of Mondays with Maishi. This is Maishi Norman, your host from Lakewood, New Jersey, and tonight is Monday, surprisingly, September 15th, 2025. We are now 5.5 years into the show. I don't know, I haven't been counting episodes, but we're in the 200 range, and it's really nice to spread out a little bit, once in a while, talk about something. Uh, um, I guess within the range, but not exactly related to psychotherapy, which was the original mission statement of the show to talk about the process of psychotherapy. But here we have some intersects that, come up every once in a while, either in conflict or in tandem with the work that we do. And one of them that's been discussed for quite a number of years. I spent a lot of time, maybe it was a dozen or 15 years doing IIC work. For those of you who are not familiar, it's a program in New Jersey for children who are struggling in crisis intervention. So it's where they're exhibiting a tremendous amount of aggression, dangerous behaviors, those who have just are on the way to the hospital or on the way out of the hospital. It's an IIC, it's intensive in community counseling, where we worked in the community and we worked in home. So we worked with children in their homes, and we got to see all kinds of unusual things that we were afforded as in-home or in-community counselors to see and to experience that others who work in outpatient settings don't get to see, which is really the family system, how families work and what goes on. And you get to often see children behave in ways that they're more comfortable behaving at home that they might not be in an outpatient setting. And what's come up many, many times is the idea of autoimmune disease or autoimmune challenges that children have. And it's been very contentious because it's hard. I found it very, very difficult to determine when parents were saying, my child was diagnosed with an autoimmune issue, they were diagnosed with PANDAS or PANS or something in the family or some other autoimmune. And I struggled very much, to either trust because there was such complicated or sloppy or ambiguous data, or I should say controversial data is probably more the word. Does this really exist? Does it really affect children in this way? In many cases, we had parents who may have been, uh, struggling with borderline personality or with other disorders, Munchausen by proxy, or other disorders. It was really difficult for us to determine whether the parent was being truthful, the parent was convincing the doctor was convincing the parent, like what's really going on over here? And especially in some of these disorders that's symptoms are really not specifically consistent. So we may see these symptoms A and B in one person, and they get diagnosed with diagnosis A. We see symptoms D and E in another patient or child, and they get diagnosed with the same autoimmune disease. Now, what's going on? So it was very, very confusing. I found it to be very confusing. I found myself really struggling to believe and trust. And then we had people doing all kinds of treatments for these autoimmune disorders. And we saw children who were not successful, and the parents were saying they were successful. We saw children who were successful, and the parents were questioning it. We saw, again, inconsistencies in success and then regression, and then some more success and then more regression. Again, I have a lot of stories from the work that I did with in the IIC. Um, Many of them did not have happy endings, unfortunately. And, to which obviously it led me to believe more and more that no, we're actually dealing with schizophrenia or something like that. And many of the symptoms were consistent with schizophrenia, but some of them were consistent with schizophrenia and then had other like questionable behaviors or very degenerative behaviors that were, questionable psychosis or schizophrenia. So I left with, the IIC world with a huge mishkabobble of confusion. And what's been up in the air, obviously, is to talk about this and to try to bring some clarity. I think I have a feeling that I'm not the only one in this boat of confused practitioners. And what I obviously chose to do is just like tune it all out, send them to the pediatrician, and have them get diagnosed and assessed when there's something that I just couldn't make sense of. But I never assumed that something was an autoimmune encephalitis or some kind of autoimmune disease. I sent that to the higher ups. I never suspected something like that, just because, again, I couldn't seem to make heads or tails of the symptoms. So tonight we invited Naomi Indich. Thank you, Racheli Sternheim, who's here, who made the connection, and we invited Naomi Indich, who is a a pediatric nurse practitioner in, I don't know, is it Fair Lawn? Or
Yes.
in Fair Lawn, New Jersey, who is supposedly a great expert in treating pandas and diagnosing pandas. And so, Naomi, thank you very much for coming on and agreeing to present and discuss this topic with us tonight. And I hope you'll be able to shed some light and bring some clarity to the many mental health practitioners who just want to understand this whole idea, this whole uh, parsha better. So, thank you.
My pleasure. That could help.
So Naomi, tell us a little bit about your background and exposure, or maybe that's a bad word, to pandas and how you became familiarized with this and developed expertise in it.
I was lucky enough to train with Dr. Susan Schulman, who, if anyone has ever heard her, I'm sure people have. She's an expert in pandas. She was an incredible pediatrician, aside from being an expert in pandas. She was treating pandas for about 20 years before she retired. Um, and so, as a nurse practitioner, I had the good fortune, I guess, of training under her. So she trained me in everything pandas and then retired and left everything to me. So
So
she,
tell me, who was Dr. Schulman and is Dr. Schulman, and what was her interest or fixation on pan? Like, how did she get involved in that?
Dr. Schulman was one of the top pediatricians in Brooklyn, if not the top. She was very outspoken. She would talk on a lot of controversial topics like child abuse in Borough Park and safety awareness, and she would just speak about everything. She had a really strong kofa dibra, so she was able to talk in public in a lot of different areas, and she was able to get across to a lot of people. She was an excellent, excellent diagnostician, and she was practicing for about 20 years in general pediatrics, um, in private practice in her home. And she said in those 20 years, she maybe had 3 kids with psychiatric mental illness. And in 1 year after that, in sometime in the 90s, she noticed in 1 month she had 3 patients that developed OCD. And all of them were falling with strep. And so she went online and she Googled and she looked into like what it could be. And she found an article written by Dr. Susan Sweeto about pandas. And she emailed her right away. And she said, I think I'm seeing what you're writing about here. What do I do? And so that's how she got into it, because she saw it with her own eyes. And she was working in Borough Park. She was treating kids, and then they grew into the parents. And she was treating their kids and grandkids and great grandkids. So she had continuity in her patients, very strong continuity in her patients. And so it wasn't like she all of a sudden started treating a completely different group of people and all of a sudden she's seeing these new things. Um, and as she became aware of it and she was seeing it more, likely because it really wasn't around as much before that, she would try different methods to try to help them. And as things were working, she stuck to it. So she treated pandas for about 20 years. She was a top specialist in this field, a pioneer in this, and she did some really great things for a lot of people.
Okay, phenomenal. So, okay, so let's get a little bit into the meat and potatoes of pandas. And I do want to encourage all the mental health professionals that are on this call, as always, to please raise your hand using the React tab and wait for us to call on you and ask any questions you want. Because again, I believe that this is something that's so loaded and obviously very underused and underappreciated if we can really get to the core of this. So tell us a little bit about what PANDAS, first of all, what does it stand for? What is PANS? What is PANDAS? And what is it?
Okay. So PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Strep. When it was first discovered, they thought it had to be strep 100% of the time. They since realized it could really be any infection. It does not need to be strep. So they changed the name to PANS. which stands for pediatric acute onset neuropsychiatric syndrome, which takes the strep piece out of it. Some people still like to call it PANDAS because it's the word they're familiar with. Some people like to call everything PANS. Because of the controversy, as you mentioned before, and getting certain treatments approved, the actual name keeps changing from like a clinical perspective. So the PANDAS community really prefers the PANS name. But out there, whatever, live, um, it either one really tells you what you're trying to say, and so it really doesn't matter that much. And so what it actually means is P is pediatrics. It most commonly happens in kids. It can happen in adults, but it is more common that it happens in kids. Um, Acute onset or autoimmune. So autoimmune, when our immune system functions properly, you get an infection, your body notices something that shouldn't be there. It sends the full artillery to kill off that bug that shouldn't be there. So like all the different types of white blood cells go to kill this off. And then they take notes and they create something called memory cells. So they kill off the bug, they go back to home base, they file away these memory cells. And the next time you get that same infection, you have the memory cells there, which are a form of Th17 cells that can go and kill off that bug. So your response the second time you get an infection is much lower than the first time. So if you think about, let's say, COVID, when COVID first came out, no one had any protection against it. So everyone would get sick. And some people were dying. Some people were getting very sick. Some people had a cold, depending on how their body responded to it. Now, most people are just getting a cold because now we have protection against it. And so our immune systems are not as overtaken by it. So that's a regular, normal immune system. Autoimmune is when the body, instead of attacking something that shouldn't be there, like a bacteria, it attacks something that should be there. So for someone with diabetes, it attacks the pancreas. For someone with psoriasis, it attacks the skin. For someone with PANS or PANDAS, it attacks one area of the brain called the basal ganglia. And the basal ganglia is responsible for neurologic and psychiatric function. And when it attacks the basal ganglia, it causes a stippling of inflammation. And I suspect, although I can't prove, depending on where the inflammation is most likely depending on the symptoms, which is why different people have different symptoms. It's not the whole basal ganglia that's inflamed, it's little dots throughout it. It's not a big enough area in one spot for it to show up in typical imaging, but there was a machine that was in research in Delaware. It was a cross between a functional MRI and a PET scan that was able to image it. So if anyone's interested, you can look up an article by Dr. Shugani and he'll talk about it. Anyways, so it causes neurologic and psychiatric symptoms, and then we associated with strep versus syndrome we've already discussed. So that's what it stands for.
Mm-hmm. Now, when we talk about, let's say, autoimmune encephalitis, isn't that also a swelling of the brain? Is there something different between that and PANS?
PANS is an autoimmune encephalitis of the basal ganglia, meaning autoimmune, we already discussed. Encephalitis is inflammation of the brain. So different areas of the brain are different autoimmune encephalitis states.
Got it. Okay. Okay. So that's what PANS is, and then it's causing neurological and psychiatric type symptoms.
Yes. So sorry, did interrupt for 1 second. Sorry. Oh, sure. I missed one piece. So basically what's happening is the kid gets an infection. We've already discussed that it's not always strep. However, strep, as we know, does this in the body. It does it in rheumatic fever, it does in glomerulonephritis. So it's not crazy to think that strep it's exactly the same thing, just in the brain instead of the heart or the kidneys. So in my opinion, it's probably strep that sets you up for it because strep has been known to do this. And then once it sets you up for it, any infection can bring out the main symptoms. It's neither here nor there, and it doesn't actually matter that much in terms of treatment. But what happens is you get an infection, your body produces antibodies to fight that infection. Those antibodies fight the infection, and then once they're done fighting the infection, they are circling and they go and attack something that they shouldn't attack, in this case, the basal ganglia. They cause a stippling of inflammation. Depending on the inflammation, will cause different symptoms. So psychiatric symptoms would be like OCD, anxiety, separation anxiety, I'm sorry. Neurologic symptoms could be tics, bedwetting, previously dry, day wetting when previously dry, sleep disorders, cognitive dysfunction, sensory hypersensitivity. It can really be like so many different neurologic and psychiatric symptoms and so many different combinations of them.
Hmm.
Rages could be, there are a lot of things that we see. It, in the actual definition that you'll see online, it's not necessarily so clear cut. It's an old definition. The consortium is working on changing that, but for right now, that's what we have.
Okay. So explain to me what happened when Dr. Schulman suddenly saw what she hadn't seen in 30 years. She saw in 3 months or so. I forget what you said. Right. What happened? What happened that she suddenly had three patients with these symptoms?
Well, you're what happened, meaning why did it all of a sudden start?
Why did it all of a sudden start? Why did she start
Prior
seeing it
prior to that, rheumatic fever was rampant. It's very rare that we'll now see a case of rheumatic fever.
today? Today, rheumatic fever is
It's
real.
much more rare. Yes.
So you're suggesting
So
that?
strep just learned to do something different, most likely.
Mhm.
Either that or it's a new entity and the immune system malfunctions in a different way for other reasons. It could be food related, it could be the environment. There's so many answers
Mhm.
that could be suggested and possible. We don't really know.
Okay. So if we see a child, so now, when would we begin to look or suspect or wonder about PANS? Is it sudden onset, something that the child wasn't always exhibiting, and there's a sudden onset?
It could be a sudden onset, but it does not need to be a sudden onset. Meaning every time a child gets sick, they may have some symptoms, or they may even have a lot of symptoms, and then add their let's say they get strep. They get, let's say, very bad ticks, and the ticks go away. The first time they get strep. The next time they get strep, maybe they get ticks and a little bit of anxiety, and the anxiety is a 10, and then the anxiety is down to a 2, and they're not really thinking about it. And the next month, the anxiety is like a 3, and then it goes a little worse and lower. So it could be gradual with illness. It could be a sudden onset. Very often it's a sudden onset, but it doesn't have to be a sudden onset. And it's really a change in the child without another reason.
Hmm. So okay. So I'm just thinking, as parents and practitioners, you're giving a very, very vague description because all these symptoms could be mental health related or neurological, right? And if there's nothing glaring to say, oh my gosh, that was a sudden onset for no reason, unless there was a trauma or PANS, when would we start suspecting or thinking along the lines of let's have them checked, let's have their blood level checked?
It's not a blood level that gives an answer. It's the clinical diagnosis. So the blood test can help maybe identify the cause, the infection that caused it, but the blood tests are not diagnostic in any way. When I do a consultation, it takes me 2 to 3 hours to go through each symptom and to try to determine where it's coming from and if it could be from this or from something else. So if a kid is an anxious kid when he's born, he's an anxious kid when he's 2, he's an anxious kid when he's 5, it's the kid that has anxiety. If the
Mhm.
kid's parents are super anxious and the kid has anxiety, that makes sense, right?
Mhm.
If a kid was a super calm, chill kid, he did great in first grade, second grade, all of a sudden in third grade, he can't keep up and he all of a sudden developed ADD when it wasn't a kid that you suspected would have ADD at a younger age.
Mhm.
There's something else going on there, most likely.
Mhm.
If a kid was a super calm child kid and he all of a sudden developed anxiety and he didn't have anxiety before that, there's usually a reason for that. Now, yes, it could be abuse. You have to
And
roll.
yeah, I was going to say, when you do your assessment, how do you take into account, let's just say, trauma or other such events that may have brought this on?
I ask about everything. I look into those things too. I will go through with them the full situation of everything surrounding what happened in the onset
Okay.
and even moving forward from there.
So when should we mental health professionals start thinking along those lines of, like, maybe what's going on here needs to be assessed by an autoimmune expert or a pediatrician who believes in, subscribes to PANS?
Any patient that comes in with mental illness, it should always be a consideration.
Hmm.
Meaning it may be anxiety, and you're looking at, this kid had anxiety his whole life. His parents are like super anxious. Obviously, there's a reason. Or this kid had a terrible school year last year because the Rebbe was abusive.
Hmm.
Let's look at the anxiety. But at the same time that you're looking at that, you're thinking, is there another cause of this? Meaning it's not saying that the kid doesn't have anxiety. That's non-negotiable. If the kid has anxiety, the kid has anxiety. The question is there an underlying root cause that needs to be addressed as well?
Mhm. So you're saying, okay, so I'm still not sure I understand the answer. You're saying it's part of the assessment process should be, do we have any questions that we can't really answer from an obvious or ostensible mental health perspective? And if we do, then we should obviously go medical, which we always try to, it's one of the parts of our psychosocial assessment is, biopsychosocial social is to go medical, to always keep that in consideration. I'm just trying to figure out, like, if I see 100 kids, which one of those 100 should not be going for an assessment for PANS, uh, if they're exhibiting anxiety. And so I hear you saying if it's unusual for this child, right?
Yeah,
If we can't attribute it to something else that's evident or evident
right,
enough.
right.
Um, and then I guess if they exhibit some of the classical symptoms, would you say, like, do any of the classical, or are there classical PANS symptoms like tics or OCD symptoms that have to be that should be present for us to suspect?
I mean, OCD is going to present as organic OCD even if it's PANS,
Hmm.
meaning it's presented the same way if it's organic mental illness versus autoimmune encephalitis, right?
Right.
So it's really, but if a kid didn't have OCD at 6, he shouldn't have it at 8.
Hmm.
The kid didn't have, if he didn't have any OCD tendencies, or even if he did have OCD tendencies and it blew up at 8, that's not a normal age for a kid to develop severe OCD. It's more common nowadays,
Hmm.
but it wasn't in the past. And so why is that happening? And is there an organic cause to that? Or
Hmm.
is there something else going on there?
Right.
So I understand that you want me to give you very clear cut guidelines. I can't do that. You can
Well,
give
I
me
don't
a
want you to give me,
situation. I
I'm
can
not
keep it.
looking for clear-cut guidelines on who has pants and who doesn't. I'm saying as mental health professionals, what would the clear-cut guidelines be for whom we should be assessing, we should be referring? That's really the question.
So any kid, first of all, if they're not responding to therapy
Hmm.
and you believe they should, then you should always look into other options also.
Hmm.
I find therapy is very helpful once the PANS is a little bit more under control. But when they're at the beginning, before it's starting to be treated, it's not as useful to them because their brains aren't open for it and ready for it. And sometimes it can cause them to not want to try therapy later on when it could be more
Hmm.
useful. So that is something to keep in mind also. But if you're doing therapy on a kid and it's not working at all and you don't see any progress and you're thinking, and as you're doing the therapy, you're coming across things without a specific, listen, if they have tics, if they have a neurologic symptom, then it's a little bit more clear cut. So it's a little easier, like, oh, you have tics,
Yeah,
plus
for
you have
sure.
this anxiety. Go see a PANDAS specialist and see if it's something that needs to be looked at more, right? In that sense, I feel like neurologic symptoms are a little bit more of a bracha because they're a little bit more clear cut.
Hmm.
But aside from that, when it's just psychiatric symptoms, it's really just about looking at the symptom and the background behind it, and is it something that makes sense for this kid or not?
So I want to ask you a question because this came up so many times when I was treating kids who were diagnosed with autoimmune encephalitis. Um, the doctor wants them to be treated for the autoimmune encephalitis, for the PANS, and they also want them to go to therapy to work on the behaviors or something. I really always struggled with that idea, with that concept. In other words, if what's ticking the kid, no pun intended, is something that's autoimmune or something that's swelling in the brain, then what is the purpose or the value of getting psychological treatment, I guess you would call it, or even behavioral treatment? Is there any value to it?
So I use therapy and mainly cognitive behavioral therapy when their symptoms are much better. So when, let's say, their symptoms are, I'm scoring it, let's say 0 to 10, right? 10 being the worst it could be and 0 being their baseline. So if their symptoms are at a 10, I don't even discuss therapy because it's not
Mhm.
going to do anything and there's no reason for it. When their symptoms are a 1 or 2, that's when I find cognitive behavioral therapy can be helpful in the sense that it can help get them off the antibiotics quicker because it can help mop up some of the leftover stuff. It's not, but really, you need, and at that point, most of the inflammation is brought down. It's just getting the rest of it gone. So it's not, I don't really believe that when at the beginning that therapy is helpful. Afterwards, they may have some PTSD. They may need some therapy for that.
Yes, and then
And parents for
that wouldn't
sure.
necessarily be cognitive behavioral therapy then.
No, that would no, not at all. But for the cognitive behavioral therapy, it's when the behavioral symptoms are very mild, it can help teach them tips and tricks and tools for future. So it's never a bad thing to do in general.
Yeah, I mean, for parents, it's costly. Sometimes for the therapist, it's very frustrating because again, if we're dealing with somebody who's not in his sanest place to be able to have control over his behaviors, then it's going to be very difficult to be successful with them.
So when the patients are that bad, it's definitely not a good idea.
Okay.
But when the symptoms are very, very mild, it can help get them through it faster. Just the end of it.
Okay.
To answer your question.
Yes. Yeah, I have more questions though. There's so
Go
much.
ahead.
Well, let's talk a little bit about treatment, the treatment itself. What is the treatment for this disease?
Okay, so there are different treatments for
And I
this.
just, by the way, I just want to remind for all those of you who came on late, if you have a question or a comment, to please click the React tab on the bottom of the screen and raise your hand. We'll call on you.
So, first treatment I most commonly try is antibiotics. And there are different antibiotics that have anti-inflammatory properties. And so it's really the anti-inflammatory properties that are working on taking down the inflammation, while the antimicrobial properties at the same time can help give some sort of protection against infection to give them a chance to heal. Now, I mentioned before that the labs are not diagnostic. There is one caveat to that. When there is Lyme disease or tick-borne illness involved, the labs could be diagnostic since that can cause these symptoms as well.
I'm
So,
sorry, I missed that last thing you said. Can you repeat that?
yes, with Lyme disease or
Ah,
tick-borne illness, the labs could be a little bit more diagnostic. So if there is something that comes back positive with Lyme disease or tick-borne illness, then that needs to be treated. That needs to be treated as well. And hopefully, I like to treat it with medications that also have anti-inflammatory properties.
but I was gonna, can I jump in on that for a second? I mean, if what we're looking for is anti-inflammatory, if you treated them with a regular analgesic, some kind of anti-inflammatory Motrin or something like of that nature, would you potentially see a reduction in symptoms? I actually remember reading somewhere years ago that they found that some of these anti-inflammatories actually reduced depression, and that a lot of depression was
They
coming
have
from inflammation, right? Am I making that up or did I see that?
no, they have anti-inflammatory properties in Prozac.
Anti-inflammatory.
Properties in Prozac and
Oh,
a lot of antidepressants actually in
okay. So,
SSRI.
so if you would give them a Motrin or Advil or something like that, would you see potentially a short-term reduction in symptoms?
So yes and no. That depends on a few different things. I do use Motrin commonly for flare-ups since it is very common, even when the child is in a good place, for them to have a flare-up of symptoms, meaning they get worse um, from being sick or being around someone who's sick. And that's when I find Motrin to be very helpful to add on to the other inflammatory properties, anti-inflammatory properties of the medications that they're already taking. But to give it to there are some doctors that will give medications that don't have anti-inflammatory properties, like Caflex, for example, with Aleve, naproxen. I That's just not the way I was trained, and I haven't seen it work on the one or two patients that I've tried it for different reasons. So I don't do it that way. Steroids like prednisone are a very strong anti-inflammatory, and they can help. However, when the kids first of all, very often, even though you'll see the symptoms go away very quickly often, um, they come back right after you stop it if they're not ready for it. So I don't use it off the bat. And also sometimes if they're really bad or if they have tick-borne illness, Lyme disease, the symptoms could get worse.
So would one way to test whether this is inflammation related, would that be to take an anti-inflammatory for a couple of days, see if there's a reduction in symptoms? Wouldn't that be telling and valuable?
Um, if it works, yes. If it doesn't, no. Meaning if the kid's very bad, probably a week of Motrin is not going to make the symptoms go away.
Okay.
Most likely, I would
Okay.
even venture. Like,
But it can be telling, is the point is it can be telling if they take some kind of anti-inflammatory or a strong anti-inflammatory and we see reduction.
well, you say strong anti-inflammatory, but very
You
interestingly,
said like steroids.
well, steroids, I would not recommend people take steroids as a tester because it can make, if they're really bad, it can make them worse, which then they may not want to use later. Also, side effects of steroids could be rages or different, regardless, you don't have to have PANDAS in general. Anyone who takes steroids, some of their side effects could be raging or aggression or tics or anxiety. So my patients that I'm giving it to for a reason, I tell them if you can push through it, because it doesn't mean the steroids aren't going to work. That's not a PANDAS side effect. That's a steroid side effect. And then we'll see where he comes out at the other end. But just to try it on everybody is not the answer. It can also interfere with tests later on.
Okay. Okay. So anti-inflammatories, like over-the-counter anti-inflammatories, may be
Well,
okay, but not good proof, not good evidence. But if it works, then it works.
if it works, it's good evidence. If it doesn't work, it
Good
doesn't mean they
evidence.
don't have it.
So let's talk about antibiotics. So first line of treatment you said is typically antibiotics. And then how long is that for? Because I've heard of like people being treated with antibiotics for years, and then a lot of contention on that about it being bad for the immune system or for other parts, of the body. Tell us a little bit about that.
So antibiotics are terrible for you. No one's going to contest that. However, having inflammation in your brain and having psychiatric symptoms are also terrible for you. So you have to always weigh the risk and benefits to everything. So I start with a month of antibiotics. If I see improvement on that antibiotic, but they are not completely back to their baseline after a month, I continue it. If I see no improvement after a month, I try a different antibiotic. And I get updated on a monthly basis every 4 weeks. And if they're continuing to improve, I continue it. If they're not, then we're talking about what's going on and if treatment needs to be switched up. And once they're completely back to their baseline and stable for about 4 weeks, that's when I usually try to start tapering them off. And I taper them off slowly because not because of the antimicrobial properties, but because of the anti-inflammatory properties.
So just help me because I'm not very good with medical stuff. So excuse my ignorance. But
Mhm.
why is it that if you take them off the antibiotics after a month or 2 months, that the inflammation won't just recur? Is it because there's an infection that's being mitigated or destroyed?
It can recur, actually, which is why I wait for them to be completely stable for at least a month and then I slowly take it off. I don't just stop it
Hmm.
because they could. There is one school of thought that there is a latent infection involved. And so the antimicrobials are treating that latent infection while the anti-inflammatory is mopping up the inflammation. That's just one school of thought. That's not what everyone thinks. But even if that's the case or not the case, the antibiotic and the anti-inflammatory properties, it's the anti-inflammatory properties that need to be tapered off. If you stop it too soon and the symptoms recur, it could be a lot harder to get under control the next time around. So it is important to make sure
Why
that
is that? Why is that?
I don't know.
Just works that way.
That's just been my experience.
Okay. Okay. So then what happens if first line of treatment doesn't seem to be helping much?
Then there's IVIG or plasmapheresis or rituximab. I don't do rituximab; it's out of my scope. But I do IVIG and plasmapheresis on kids that need it.
So I've worked with kids who are treated with IVIG, with all these things, and the feedback was so complicated. The mother is sure that the kid's getting better. The father doesn't see any difference. Now it's 3, 4 years later. The kid's a bigger mess than he was then. A number of children that I've seen this way. I mean, first of all, what is IVIG? Tell us a little bit about what are the properties in that medication, and then why are these things happening? Are they convincing themselves that this is really an autoimmune disease because of some reason, the parents, or is the treatment just not working, or what's happening?
Yeah.
Obviously, you don't know the case, but
Right. So I can't speak to the case that you're talking about because I have no idea what you're talking about. I can tell you from my patients and my experience.
hmm
IVIG is intravenous immunoglobulins. So when you donate blood, you're donating, they divide into different portions, and one of the portions is immunoglobulins. And about hundreds of them are pulled into one little unit of IVIG, and that's IG immunoglobulins is what makes our immune system function. It is made up of immunoglobulins. So when you give IVIG to a patient with autoimmune encephalitis, the idea is that the good immunoglobulins that function properly can knock off the bad ones and at the same time give the immune system a little break and hope that when the immune system starts up again, it can start up functioning properly again. And at the same time, the bad immunoglobulins can flush out of the system. Now, it can take 3 months for the bad immunoglobulins to flush out of the system. So, the one downside of IVIG, it's a very safe medication overall, The one downside with my patients is that about 50% of my patients will get worse before they get better from IVIG. And that has a lot to do with most likely the die off of the bad immunoglobulins flushing through the system.
For how long though?
3 months. I have patients that literally have emailed me day 87, this is not working, he's terrible. Day 90, I spoke too soon, I'm starting to see an improvement.
Mhm.
Literally 90 days to
I'm
the day,
talking
most
about
better.
4 or 5 years. That,
Well, okay. So getting
that
one dose of IVIG and
yeah,
not,
obviously they didn't get one dose of IVIG.
they what?
No, they obviously went through for series of treatments, IVIG treatments, and what I'm thinking is that maybe it was never an autoimmune disease,
Or maybe it wasn't the right treatment.
or maybe it wasn't the right treatment.
If IVIG doesn't work for everybody. It works for about 80% of patients.
Hmm. Hmm.
If IVIG doesn't work, I move on to plasmapheresis. If plasmapheresis doesn't work, then rituximab may
Some of
be
these
needed.
things, my understanding is it's very hard to get insurance to cover them. Is that right?
Plasmapheresis is easier to get insurance to cover than IVIG. But a lot of the times I can get the IVIG covered. It just takes time. Wait, I was going to say something and I lost my train of thought. Sorry. Oh, I had it. I'm sorry. It'll come to
Okay.
me.
I'm looking at a list of questions that somebody sent me. For those of you who have questions and want to ask them live, just click the React tab on the bottom, raise your hand, and we'll get your question in.
I can't believe no one has questions.
Well, I'm looking at the list of questions and pretty impressive that you answered. Oh, there's 9 questions here so far. The 3 or 4 are already answered. Okay. Oh, here's a question. Will the condition ever go away, or will you just be managing it until adulthood?
That's an excellent question. And I don't really have an exact answer for you. For some kids, they get better with treatment and it goes away and they never have another experience with it. And for some kids, every time they get sick, they have an experience with it. They relapse. Sometimes it's easy to treat, sometimes it's not. Lately, in the past couple of years, I've been using a medication called low dose naltrexone, which has been used. It's being used now for a lot of autoimmune illnesses. Naltrexone is a opioid antagonist, so it's used for addictions. It blocks opioids in high doses. In very low doses, in doses of like maybe maximum 4.5 milligrams, when the regular dose is probably 50 or 100 milligrams or even higher than that. So in very low doses, it has been shown to have anti-inflammatory properties and immunomodulator properties. And what I am finding with the low dose naltrexone when given long term is that it's been preventing over time the flare-ups become less and less intense and less frequent until they stop completely.
Mhm.
So it is the one thing that I'm seeing. I asked me in a few years if it helped, but there are a couple patients that I've had it for a few years.
Is that a commitment to be back on the show in a few years?
Huh?
Is that a commitment to be back on Mondays with Moishi in a few years?
Absolutely.
Okay. Got it.
um, so there are a few patients that I've had on it for a couple years now that I have one patient specifically. He needed plasmapheresis. He did not respond to any antibiotics. He did not respond to IVIG. We gave him plasmapheresis when I was still working with Dr. Schulman. We gave him plasmapheresis. He got completely better.
Hmm.
Every year to year and a half, he would have a flare up and need another round of plasmapheresis. He had about 4 rounds of plasmapheresis, and I started him on LDN after the last round of plasmapheresis I did for him, and he has not needed it since. And that was 3 years ago.
So I want to take Avi's question, but just before that, I want to ask you about adulthood. I can't recall seeing an adult who I am familiar, I've seen symptoms of PANS or PANDAS. What happens to these? You see like kids who go through different stages. They get really, really yeshivish or really, really Hasidish or really, really this, really that. And then eventually they kind of grow out of it. It's like a developmental stage where they're looking for their identity and finding themselves. Then you see kids who have all these kinds of symptoms, tics and OCDs or whatever. But then, when you see people at 25 or 30 years old, you don't see that they have it anymore. Are these things that kids kind of grow out of, or do people actually live with these symptoms into adulthood?
I have tics, and I believe I probably had pandas as a kid.
I see.
And it was not something that was really well known then. And it's also not something that's worth it for me to treat at this point in my life because they
Well,
don't
I mean,
affect
there
me.
are adults with tics,
Yeah,
right?
But I had it as a kid and I had frequent strep. So I have my reasons to believe what I believe, and it's
Mhm.
irrelevant to the point. But I will tell you that it can often, if it's not treated, it will follow you into adulthood.
It will,
It will, yes.
in some form.
Usually the symptoms just, if you had, let's say, anxiety from PANDAS as a kid, you're just assuming you have adult anxiety. But how many people, I don't know how many people you treat or how many adults you've had that have resistant forms of anxiety that are not responding to medications and they're self-medicating with alcohol or other things. I know a few adults like that.
So how would you determine if they're struggling with PANS? Same
I
same.
don't treat adults, so it's hard for me to say.
How would
But
one
it's
determine?